Ivan spoke about a 20% failure rate in shoulder surgery. I mean, I'd dream of a 20% failure rate in foot surgery. It'd be wonderful. Anyhow, we do take your feedback seriously. So based on last year's feedback, this fracture topic was very popular. Most people would like me to speak a lot faster. You enjoyed my politically incorrect sense of humour and that I should be cancelled. Anyhow, I'm here and I'll try very hard not to offend people. So this isn't a talk about plate and screws, it's a talk about diagnosis of fracture and you people treating fractures. It's very important to try to make a diagnosis. It's not just the patient comes along and say, we'll try some physio, which happens sometimes, I know. But try to take a history, speak to the patient. Examine the patient, investigations. So it's a recurrent theme in these talks. You've got to talk to the patient as much as sometimes it's onerous. And the tragedy of the misdiagnosis is you see what you look for and recognise what you know. Sir William Osler, the great prince of the physicians, used to say, "Listen to the patient; they're telling you the diagnosis." All right, but Professor Tom Taylor said, never listen to what a patient tells you. Patients are liars or fools until proven otherwise. So the truth is probably somewhere in between the two. But you do have to talk to the patient. The history of trauma is very, very important. I think, if someone injures themselves on a football field, for example, are they able to keep playing? Did they come off? Were they helicoptered off? If someone's on the footpath and they twist their ankle versus someone, fell 3 meters off a ladder, the one I always see is the horse. I mean, someone falls off a horse is a big injury. And there's usually something going on. Continued sport, always important, and the crack is not always a fracture. Sometimes it's a no-brainer. You see your patient in the newspaper, and that's an easy one. But you do have to look for examination. Still these days, the most important clinical sign of fracture is point tenderness over bone. So, does it hurt, does it hurt, does it hurt? You've got to press on the bone. It's not rocket science. It's not, a diastolic murmur or something we never heard in cardiology. I've never heard one. So swelling, deformity, loss of joint movement. Okay, so X-ray. Everyone who comes and sees me says, "Doc, do I need an MIR?" Right? And they're coming to you guys too. They need an MIR because, the beautician said MIRs are real good. All right? And unfortunately, most people that come and see me have got MIR today but haven't had an X-ray. And really, the most important, investigation is a plain X-ray in someone who's had an injury. And you need an X-ray in 2 planes, including the joints above and below. Bone scanning's sort of gone by the wayside a bit. CT scanning is still the best investigation for bone. If you saw that case that Kuan Yew showed where, that triquetrum was in 83 pieces and he put it together very skillfully, the bone shows up much, much better on CT than MRI. Having said that, MRI does have a role. MRI looks at the tendon, the cartilage, the ligament, the things that don't show up particularly well on bone, on plain X-ray. So anyhow, this patient came and saw me, a little bit embarrassing. They'd had an MRI scan which showed that, spent $500 of their hard-earned. I took an X-ray and you can see fairly obviously there's a fracture there. So always do the plain X-ray first. They always try to upsell the investigations. When you see an X-ray report, MRI scan is suggested to further investigate, Okay, I see people that have had 50 investigations. They've had ultrasound, an MRI scan, an OP. It's great, doc, it's all free. It's not bloody free, all right? The taxpayer's paying for it, you and me. And you realise we've got to start saving to buy the submarines. We can't just let all this, there are some big expenses coming up. We've got to watch the purse. So anyhow, don't forget CSO. I hope I haven't offended anybody. So anyway, CT scan is still the best way to investigate a fracture because bone is rich in calcium and at fine detail, multiple planes. And if you look, I love CT. CT is a great investigation. And with the software now, they can do a CT scan like that. It used to be put someone on a waiting list for 6 months to get a CT scan, and now it's extraordinary. And they can scan people very quickly, so you can see the fracture of the talar dome, fracture of the anterior process of the calcaneus, cuboid Mornay. So you see all these things very well. MRI scan, on the other hand, depends on water content, so the detail is certainly not as good for a bone. I'll show you a case. So this lady staggered into my office, but she didn't really. She was brought in a wheelchair. And if you have a look here, she's got, a fracture of the medial malleolus, something going on in the middle, something going on in the proximal fibula. Lateral view there, you can see there's a fracture of the posterior malleolus. But when you do a CT scan, OMG, you can see it also beautifully. So medial malleolar fracture, the fragment in the middle of the joint, the posterior malleolar fracture, it shows up very, very nicely. And that investigation is relatively simple to get and certainly helps us from a surgical point of view. So ankle fractures, You all know about ankle fractures, very common, probably the second commonest injury in the foot after base of fifth metatarsal. And again, differentiate the rotation from the compression. If someone's come, 3 meters off a ladder, they've often crushed their cartilage, often poor outcome. Someone that trips on a footpath, different outcome. So in general, I'm a simple fellow. I don't understand all that stuff Ivan talked about with growth factors and TGBF and metalloproteases. These are things I've never understood. So basically, when you look at an ankle, this is the syndesmosis, which is the joint between the two bones. Fractures below the syndesmosis, bueno. Fractures at the syndesmosis, not too bad. Fractures above the syndesmosis will often cause problems. That's very simple. That's, the complete idiot's guide to ankle fractures. We talk about a thing called the posterior malleolus, which is a sort of bastardized orthopedic term. And really where it is, it's the posterior portion of the tibia, which is the attachment of the posterior inferior tibiofibular ligament. And this is the injury that you will often see with a syndesmosis injury. This is an injury that is often missed. So we often talk about the posterior malleolus. So the Weber classification, Weber was a Swiss man that made plates, and basically everybody with an ankle fracture needed a plate. Well, we now know that's not true. But in general, a fracture below the syndesmosis is stable. A fracture at the syndesmosis may be stable or unstable, and a fracture above you have to take more seriously. I often see in that x-ray that I showed earlier on of the fibular fracture, the woman did it skydiving and was walking around Europe for 6 weeks on that fibular fracture, and then didn't have an investigation until she came to Sydney. So, if someone's walking around on it for 6 weeks, it's a stable injury. It's got to be. Okay, so this is the x-ray that should never be taken. So this is the patient that, you see in the casualty, and they come in and the ankle is obviously dislocated. And we say that this sort of injury should be reduced immediately before an x-ray is taken. And what you do, you give a patient some sedation and lift up the big toe and it goes clunk. And the reason why this x-ray should never be taken is because if you leave it, the skin will poke through there or the skin will poke through there, and you will take a simple fracture that could have been treated easily into an open fracture which has its attendant complications. Okay, so this is an example of a Weber A fracture. You can see that is below the syndesmosis. It's the attachment of the lateral ligament. This fracture is stable. It will probably unite. Sometimes it doesn't unite and you'll get a fibrous union. If you get a fibrous union, it's usually painless. So this does not need treatment. This is the Weber B fracture, which is the more common one that we see. It's the spiral fracture. It's the external rotation sort of injury. If it's got an associated medial malleolar fracture, then it's by definition unstable, and that needs fixing. But Ian Harris, who sort of hates orthopedic surgery in general, he doesn't like knee arthroscopy, and he doesn't like, also he's good, he's a friend of mine, don't worry. So Ian Harris said you should never operate on Weber B fractures because they've done a study at multiple centre study around Sydney which says they all do brilliantly. And in fact, we probably have operated on too many in the past. So a fractured fibula with a little bit of displacement of the bone, but no displacement of the mortise and no shortening of the fibula will probably do okay. The one you need to worry about, though, is the Weber C, where they've got the syndesmosis injury. This is how they used to be treated, put 2 screws across. Looks great, holds the syndesmosis beautifully, but the screws tend to break. So these days we use a thing called a tightrope, which is a thing which goes across there and it allows movement and you don't have to remove it. And there are a few things more tedious than removing hardware. Actually, removing other people's hardware is more tedious than removing your own, isn't that right, guys? Yeah. Okay, so talar fractures. If you want to read one paper, no, I'm not going to say that. The definitive paper on talar fractures was a paper that came out by Coltart in 1952 in the Journal of Bone and Joint Surgery called Aviatus astragalus. And these were pilots in small planes who had their foot on the rudder pedal and crushed the plane. And when the plane crashed, they broke their talus. So if you think about it, that is the sort of level of injury you need to break a talus. All right, it's a very unusual fracture, and it's sort of a hyperdorsiflexion injury, and the talus then cracks through the midsection. So these days, things like fall from a horse, fall from a height will break a talus, but your average person that trips on the footpath will not break their talus, and you're unlikely to fracture your talus on the sporting field. So the sort of injuries that we see, talar dome injuries, which you'll see all the time. Snowboarding's been very good for business, lateral process fractures. The talar dome will always be seen in ankle sprains. You'll see it very commonly. This is what we're talking about with the lateral process of the talus. So it's this V-shaped thing which articulates there, and that's the one that snowboarders break. And I didn't understand how they did it until I tried snowboarding. It's because your foot's locked in, and as you turn, you can't get out. And that's a talar dome fracture on CT, which you see all the time. Calcaneal fractures, the classic one is is the fall from a height, but you'll see talus fractures very frequently where you'll see the avulsion of the anterior process, and that's the one in keeping with a lateral ligament injury. Fall from a height, they always say if you see a decent talar fracture like this, this sort of thing does need, you do need to sort of tap the patient's back and make sure they haven't fractured their lumbar spine at the same time. When this is, in 83 pieces, we put them back together again. As long as the joint doesn't look too bad, they do okay. There are now sort of advances in fixation where they're done through smaller incisions. But you can see fairly obviously with a fracture like this that, if you leave the calcaneus sitting underneath the fibula, the patient's not going to be happy. So you put in this sort of hardware. Interestingly, often the background of orthopedics is more interesting than the orthopedics. I shouldn't say that. So has anyone been to Seattle? It rains 300 days a year. Okay, and people get depressed and they jump out of buildings. And as a result of that, they break their heels. So the guys in Seattle became expert at fixing calcaneal fractures. You see, so, necessity, the mother of invention. So these guys invented the surgical approach because they used to say never touch a calcaneus because they all do badly. But the Seattle guys started operating on them and operating them safely, and they gave people a better outcome. On the subject of Seattle, navicular fractures, the simple navicular fracture that you'll see where a small avulsion of the dorsal capsule again can be treated like a sprain. But if you've got a major compression fracture of the navicular, where you can see this is navicular in 33 pieces, they do really badly, because the navicular is terribly important in the movement of the subtalar joint. It's a very hard one to reduce, and the results of treatment are not great. Navicular stress fractures, you'll see these quite a bit. We'll talk about them later, but anyhow, you see them in athletes. You've heard about the G spot, or they talk about the N spot, so they're sore on the top of the navicular right there. They're frequently missed, but they often occur in runners and in soccer players and people like that. We were taught to fix them by Bob Anderson, who looked after the Charlotte Hornets, and that's another story. Have I got time to tell a funny story, Daron? Yes. I have, okay. So LeBron was treated recently. I don't know if he's gone. So LeBron was treated recently. He saw 3 orthopedic surgeons in the United States, and they all said, "Oh, you need surgery, and you can't, you won't be able to play for the rest of the season." So then LeBron went and saw another surgeon who treated him non-operatively, and he got back. So LeBron wrote in the paper that I have seen the LeBron James of foot surgeons, and he got me back on the field. So I contacted all my mates in the States and I said, which one of you is the LeBron James of foot surgery? And it's Bob Anderson, who's the guy who taught us how to fix these. And I said, what was he like? He's an amazing fellow, huge guy, very intelligent, asked all the right questions. But when he came in, I was going to say, I'm not actually the LeBron James of foot surgeons, I'm the Michael Jordan of foot surgeons, but I didn't want to upset him because he was much bigger than me. So anyhow, so a funny story. So Bob told us how to fix these. This is the navicular fracture, so you do it through an incision, that big thread, a screw across, and usually they heal. That's the navicular stress fracture. Cuboid fractures, you don't see them that often. That was the CT I showed earlier on, but orthopedic surgeons love Bunnings, and so there's now, there's a kit where you can have the plate which is specifically contoured to the cuboid, and you can spend, hours there putting it together with variable success. Fractured fifth metatarsal is the commonest foot fracture. In general, the tuberosity fracture is benign, the shaft fracture is benign, and the Jones fracture is not benign. So when you look here, the tuberosity fracture occurs in the cancellous bone, which is this portion here. Daron told you, you eat a chicken leg, it's the bit on the end. And it's joined together by, the attachment is the peroneus brevis tendon, the lateral cord of the plantar fascia. And what happens is that they twist and they get the fracture, and you see it very commonly. So this is through cancellous bone. And this fracture will usually do well. This fracture, put the patient on crutches for a few days maximum, put them in a boot for comfort. Often I see people say, I've been told to wear the boot 24 hours a day so the fracture doesn't move. Man could not have evolved if you had to hold fracture still 24 hours a day. So when you leave, the boot on overnight, you increase the risk of joint stiffness, DVT. So, let them take the boot off in the shower, take it off in bed, encourage them to move it to decrease the risk of DVT. And this fracture too, you don't wait for callus to form. This fracture will form by primary bone apposition, where you'll see callus in a shaft fracture. So I often see a patient that's been in a boot for 8 months because the person treating them has been waiting for callus. Well, you can wait for callus until the Paris Olympics and it's not going to come. Okay, so the shaft fracture, this is an interesting one. This is the so-called dancer's fracture. When you look at the x-ray, it looks terrible. And the patient thinks, oh my God, my life is ruined, and they're referred to you urgently. They'll need plates and screws and all that kind of stuff. This fracture actually heals very well. And you can see the callus there bridging it. The bone will remodel. You understand that bone is the prince of tissues, right? So when you break a bone, you get a whole new bone. right? When you have a heart attack, you get scar tissue. When you have lungs, you get pulmonary fibrosis. When you have a stroke, you get glial tissue in the brain. But bone is the prince of tissues. You get a whole new bone when you break a bone. So that's one to remember. So the diaphyseal-metaphyseal junction is the Jones fracture. This is the typical example of the Jones fracture. You see it there. And it can occur initially as a stress fracture, or it can occur as a traumatic fracture. This one here, we're told, is a vascular watershed, and they don't tend to do that well. In the elite athlete, we're often pressured to fix them on day one. I saw a kid yesterday who'd had one, and he was 20 years old, and starry-eyed parents, he's going to be the next big thing in soccer. He's playing 10 days a week. And, and he was put in plaster. And at 6 weeks, he's got ongoing pain and it hasn't healed. So you've now got to put a screw across it, and he's got another 6 weeks until it heals, and, uncertain outcome. So this is a sort of one where, in an elite athlete, I will offer them internal fixation on day one. And that's what it looks like. You thread a screw across. Sometimes if there's a void, you put a bit of bone graft in the side. The other thing too is that we've all been stung with these in the past, of thinking that they've healed, and then you send the patient back and they fracture around the screw. So important point is to just get a CT scan to make sure they've joined. Isolated metatarsal fracture, you can see that there. That tends to go nowhere because the other metatarsals splintered. So if one's broken, you've got 1, 3, 4, and 5 that look after us. So 2's broken, 1, 3, 4, and 5 splintered. And again, you manage that symptomatically. That patient can go into a shoe and they're happy. Toe fractures, usually if the toe's obviously bent, and it's usually, the little toe that gets caught on the furniture or the bed end, local anaesthetic, pull it straight, bit of gauze in between the toes, hold it for 3 or 4 weeks. They usually heal very well. They don't need surgery in the vast majority of cases, but just warn the patient that they'll have swelling. If a lady wants to wear a nice shoe at a Christmas party, she won't be able to do it for some time. Now, just indulge me. That's the tourmalet. Any of you cyclists? All right, you are, yeah, okay. I recommend when you have your midlife crisis, go and do this. This is one of the big climbs of the Tour de France. And it's about 25 kilometres uphill, and it's just absolutely brilliant and slightly more interesting than foot surgery. Thank you for your attention.